Hey, hi everybody, welcome back. Maybe it's your first time to join us today. If it is, we're happy you're here. Our next topic is a relatively new one based on the presentation of a number of FA patients with varied neurological symptoms that have rather perplexed the clinicians. Until recently, little was known about the effects of FA on the neurological system. So thankfully though, brilliant and dedicated clinicians are looking very closely at this issue, hoping to find answers and solutions. One of those is Dr. Stella Davies from Cincinnati Children's Hospital, here today to share her knowledge on neuroinflammation in adults with FA. So Dr. Davies, welcome, and thanks for being here.
Excellent. And I just have to tell you that my next door neighbor's just started blowing his leaves. So if it sounds like I'm in a jet taking off, it's the leaf blower, okay? So we're going to talk today about neuroinflammation. And neuroinflammation is an inflammatory event in the brain. And just want to say right at the beginning that some of this sounds a little bit scary. And so one of the first things I want to say is that what we're talking about now is rare. But it's rare and it's something new. And when things are new, we don't know everything about it. So we're learning more over time. But happily, even now we're actively looking for it. This remains a rare event. But I think it is very helpful for people in the FA community to be aware of it. Because if something like this happens to them, it's perfectly reasonable to think that doctors might not know about it. So awareness is important. So I'm going to talk first about what this thing looks like. And I've put here index patient. That's what we tend to call the first patient who's ever noticed to have some disease. So every disease kind of has its index patient. And this patient is 23 years old. She's a young woman in college and has Fanconi L. And this person has had a successful transplant for marrow failure the age of about 10 years. And she came to the hospital with a sudden onset of a left-sided visual field defect. And that means when you look to the left, you can't see that half. So if you imagine your vision straight forward, the left sides were both kind of blacked out. And you sort of know you have this because if you look straight ahead, you can't see the little bits over there that you can normally see, and you have to turn your head to see it. And this was only there for about 20 minutes, but it was very clearly abnormal, so she came to the hospital. And when we talked about this, and you know how it is when you think back, you think of things, you think, oh, I didn't think so much of that at the time. She reported about 2 years previously that she'd gone numb in her right arm, in the hip, and in the tongue, and had slurred speech for about 20 minutes. So it doesn't sound very dramatic, right? But this was an important thing, and it was important that she came to the hospital to talk about it. So when you come to the hospital with something like this, we're always going to do a brain scan and look and see what's going on. And of course, when we look in somebody who has Fanconi anemia, we're always worried about whether there might be cancer there. So this is an MRI scan, and I'm guessing some of you will have seen them before. But if you think of your head like an egg, this is looking down on top of the head, and the computer makes slices through it. So you can see the eyes here. So this is the front of the head. This is the back of the head. This is the front of the head. This is the back of the head, and you can see the skull. And this is the brain inside it. And this black area is fluid. Water looks black on an MRI. So this is the fluid that kind of washes our brains, the cerebrospinal fluid. And it flows around our brains through these channels. And you can see here in the red circle, something that shouldn't be there. And you know, the best way when we look at x-rays of something like the brain, to know that something shouldn't be there is asymmetry. So your brain, you can see here, it's pretty similar on both sides. There isn't one of these big things down here over there. So you can see this thing is black in the middle. And remember we said that was, black is usually fluid. So in this case, you call it necrotic. You imagine this is probably dead tissue. And this is bright and shiny. This is called enhancement with the contrast that's given. And this means you get enhancement when there's some active process happening. And then if you look around here, it's all darker. This is edema. Remember, fluid is dark. So this is boggy tissue. This is swelling, because there's this, you can't have a big chunk of something that shouldn't be there inside your head. Your head is like a closed box. So if something grows in it, the pressure goes up and you get kind of poofy and swelling. And it's this poofy swelling that gives the symptoms that our patient was reporting. Remember, she had eye trouble. The back of your brain controls your eyes. And this is just a different part. Remember, we're slicing through it. So this is a different slice. You can see here there's more white stuff and a little less black stuff, but it's another slice of the same lesion that shouldn't be there. So when you see something like this on an MRI, in general, this would be a brain tumor. And this is what was the concern for this patient. However, this wasn't the only thing that was wrong with this scan. When we looked at the higher slices, right up here at the top of the head, you can see here's our lesion. We're right at the top of the lesion. You can see there's more little white fluffy things, all in the red circles here. So there's lots of different little spots scattered around. So there's more than one thing going on. So that right away made people think, this is a bit odd. Because if this was a brain cancer, you would expect it only to be one thing there. And when you look further, this is right down at the bottom of the brain. So you can see that because here's the nose, here's the bottom of the eyes, this is the base of the skull, and this is the cerebellum. This is the part of our brain that controls balance and allows us to walk steadily. So you can see here, there's lots of white dots there. And our radiologist calls it brain measles. You can get measles in the brain. These little white spots that are here shouldn't be here. They're not what's meant to be there. So we've got all these little things going on all over the place. So this was a funny thing. And while we were thinking about what could this be, suddenly 3 weeks later, another patient presented. This patient went to the hospital. He's a 20-year-old male. He has Fanconi, but never had a transplant, never needed one. And he'd fallen after a collision during a basketball game. And he developed a left hemiplegia. That's weakness in the left arm and the left leg and some numbness. And just like our first patient, it resolved after about 30 minutes. Again, it's thinking back, and you know what it's like, you do blow things off, but thinking back, he remembered that he'd been maybe dragging his left foot when walking for about 2 months. So maybe gone on a little longer. But again, I just draw your attention to, this was a really short thing. It came and it went. So these are things that we need to pay good attention to. So here's the MRI from this patient. And you can see here, first thing is, it looks quite a lot like the first patient, right? So you can see down here, this is the front, this is the back. Here's our big white lesion again. So it's white around the edges and bright. So that's where the active problem is. It's dark in the middle. So that's probably dead tissue that's gone kind of liquid. And around it, there's a lot of swelling. Because see here, the brain's pushed over. This area here is where the spinal fluid flows. This should be looking the same shape. So there's quite a bit more swelling inside the head here. And that's kind of dangerous. So again, looking further around the scan, there's a lot of other things. So just like our other patient, up top, there's these white fluffy lesions that shouldn't be there. You can see some of them. This is our main lesion down here. And if we look in the back of the brain, in the cerebellum that manages balance, we've got the measles again, these white dots that shouldn't be there. So it looks like the first thing is it makes you think, well, both of them have got the same thing. So the only way you can find out for sure what something like this is to do a biopsy. It's to take a little piece of the brain and look at it under the microscope. Now, your brain's not like your bone marrow. You know, people with FA get bone marrow tests all the time and it doesn't do any harm. It's a bit bigger deal to take a little piece of brain away. But here it's really important to know exactly what's going on. You know, is this a cancer? Is this something different? So patient 1 had a brain biopsy, and this is what your brain looks like under the microscope. And the pathologists were surprised to see inflammation, inflamed tissue, but no cancer. They really expected this to be a cancer. And, you know, the thing that comes after cancer, well, if it's not a cancer, it's probably an abscess, except that it wasn't. So there was no bacteria, any infection, any bacterial infection or a conventional infection there. So we started looking for things that are different. And here you see the brown cells. These have been stained looking for something called a polyoma virus. And there it was. So that was kind of a surprise because we'd never seen this kind of thing, a polyoma virus infection in people with FA. So this is patient 1. Remember, patient 2 had very similar looking x-rays and things. And that patient had a biopsy also. And here you can see I've left the writing exactly the same down here because the biopsy really looked pretty much the same. Again, there was inflamed tissue, so that it was abnormal, but there was no cancer and there was no abscess. And again, when we looked for these brown cells that tell us that there's a polyoma virus present, here they were. And we knew to look for this because we'd seen it in the other patient. And you can see here, these are, you know, these are pretty scattered around. There's not a whole ton of them, but if you look in another part of the biopsy, you can see there's quite a lot more of them all stained around here, and these are the folds of the brain. So both these patients have got polyoma virus, and it's giving them a similar kind of inflammation in the brain that could easily be mistaken for a kind of brain cancer, but that isn't what it was. And both of these patients got steroid treatment, and their condition significantly improved, and we'll go back round to that later. So what are these polyoma viruses? So these are probably viruses you've never heard of because most people haven't heard of them because most of the time they don't cause trouble. Polyoma viruses are everywhere. And you know this idea of we live with lots of bacteria and lots of viruses, you know, that are all part of us. It's kind of one of those things. Most humans are infected as young children, and I'm talking like under 5. And once you've been infected with polyoma virus, it lives in your body forever. And most of the time, it doesn't do you any harm because we develop T cells, lymphocytes within our immune system that keep the polyoma virus down. So, you know, basically our bodies say, you can live with me, but you don't need to be causing any illness. So I've got these T cells just to keep a lid on you. So the polyoma viruses don't usually cause a problem to anybody unless the immune system is compromised. And we sort of got interested in polyoma viruses during the AIDS epidemic, when people who had AIDS, so AIDS takes away your T cells, they had the brake taken away from their polyoma virus. And we would see this virus, this kind of polyoma virus called JC virus, causing brain inflammation in people who had AIDS. So this made us think that the polyoma virus that we're seeing in people with Fanconi anemia, we're seeing brain inflammation, might be JC virus. Though it's important to note that the people who we were looking at both had quite good T cells. So this didn't kind of make sense as being quite the same as what happens in AIDS. So we took the samples, the brain samples that we had, and remember, you can't take a big chunk of brain away, you know, you need all your brain. So these samples are very tiny. And we used a laboratory technique called PCR, which amplifies up DNA to see if we can find JC virus DNA to confirm that this is true. And this came up positive in the biopsy from patient 2, who had the most infected cells. Remember, I showed you that in those biopsies, there were a lot of cells infected. In patient 1, there were fewer cells affected, and we weren't able to pull out the virus from there. But in patient 2, we were able to sequence the virus. You can look at what DNA is there and show for sure that it does come from JC virus. And we're currently also looking at a new biopsy from a third person who had a similar thing. So this is making us think that this thing is triggered by reactivation of this JC virus. So when we thought about this, these two patients coming all close together made us very anxious that there was going to be a whole lot of this in the Fanconi community. John Wagner at the University of Minnesota and myself and a neuroradiologist at Cincinnati pulled out all the MRIs that we ever had at either of our two centers to look and see if there's any of this hiding out there that we were overlooking. And we didn't find any hiding. And when we talked to people and looked around, we found 6 cases of this disease. So that's why I'm saying to you that after a good hard look in quite a big population, it's a relatively small amount. And we'll talk a bit about possibly why this might be. Let's just look at who we have. So we've talked about patient 1 and patient 2. We've got 4 other patients who are similarly involved. They've got the measles in the cerebellum in most of them. Some of them have that big mass that we've shown you, and some of them don't. So some of them have just got the white fluffy spots. There's calcium in some of them, and when we see calcium on an X-ray, that means stuff has been there a while. You'll see that most of these patients are young adults, but not all. It involves males and females, so it's nothing to do about sex. And when we look back at how long the X-ray abnormalities have been there, and we've been following them for a while, it can clearly be present for quite a long time. You don't have to have had a transplant for this to happen, because we've got people who've had transplants and people who haven't. Then we want to back up to this one with the Fanconi gene. So we've got 1 person with L, we have 2 with J, 1 with C, 1 with G, and 1 with D2. So I'm guessing that probably most people in this audience have been around FA long enough to know that the most frequent kind of FA is A. About 60%, a little bit, maybe a little bit more of people with Fanconi have A. And yet here we've got all kinds of other things and no A. So it is possible, and I told you we're still learning, but it is possible that there's something about why this is happening that means that people who are A are protected from it. Now, I don't know that for sure, but that would be a very interesting thing, because it would mean that there'd be a certain proportion of our population, a large proportion of our population, who are maybe protected from this. But this is not a sure thing as we continue to learn about this. So what happens, how does JC virus infection happen, and what does it mean in FA? So I told you that it causes problems in people with AIDS. And in people with AIDS, JC virus infection is called progressive multifocal leukoencephalopathy, which means it gets worse, it's all over the place, and it affects the white matter. And here's an image of PML. And you've seen what I've shown you about our patients. It doesn't look the same, does it? What happens in people with AIDS seems to be quite different than what happens in our people with FA. The changes that happen, they present with mental problems, they become confused, they can't speak correctly, it's difficult to move their arms and legs, and you get lesions that look like this instead of the little white fluffy lesions or the big round ones with a hole, the ring enhancement and the mass that we saw. I mentioned earlier that the JC infection in AIDS is caused by losing T cells. So we wanted to know, is this happening in people with FA? Because we've got abnormal T cells or crummy T cells. So we took blood from our patients and we tested them to see if they could make the cells that fight JC infection. And it turns out they can. These dots in this area, here we've taken T cells from patients with FA. This is patient 1, our index patient. We've shown them little pieces of protein from JC virus, and this measures whether they're trying to fight them. And you can see here, this number is bigger than here. These are good numbers. So patient 1 has got great T cells that can control JC. And when we looked at patients 2, 3, and 5, they also had very good T cells to fight JC. We haven't looked at patient 6 yet, and patient 4, who has a very mild and stable disease, did not have a T cell response. So our problem is not that the T cells aren't there, something different is going on, because our FA patients have got a good immune system that seems to be able to fight JC. So what else could be happening? So could our problem be that not that we don't have T cells to control the virus, but there's something wrong with the brain cells the virus is in? So think about this one. So if you had a transplant, you've got normal T cells, right? So they've come from your donor and your T cells are fine. So that makes sense. Some people with FA retain their counts throughout their life and have good T cells. So probably not that the T cells are wrong. So there's two parties here. There's the T cells controlling the virus that's living in the brain cells. So maybe it's the brain cells that stay Fanconi cells even after a transplant that are the problem. So one of the things that, and again, this is an idea and something that we're working with, is that the Fanconi deficient cells from people with FA, are not good at taking out and that should be trash. I just noticed that says TASH. Taking out the trash. So think about your cells. Your cells are busy all day. They get infected with a virus, they kill the virus, they clear it. You need the parts of the virus to be removed from the cell. You need to be able to control the virus. There's lots of other activities that our cells do, like making energy and things that make reactive oxygen species that can damage the cell. Your cell has trash to take out. These investigators in Beth Levine's lab have shown that Fanconi cells, Fanconi deficient cells, aren't good at taking out the trash. And taking out trash from viruses is called virophagy. And virophagy is not normal in patients with Fanconi anemia. So what we're thinking is that the cells that contain the polyoma virus, that in a regular person, the virus doesn't grow very much and you've got very good T cells to control it. In somebody with FA, the virus can grow faster. The T cells are there, but sometimes the virus can get wound up and get out of control. Now, I remind you that we're still working on this, but this is where we're currently seeing it going. And our little friends, the mice, and you know we've learned a lot about Fanconi anemia with mice, we can show that they are more susceptible to infections of the brain with viruses. So this is a good hypothesis. So how do we think this is working in regular people? So it's all about balance. So in somebody who doesn't have FA, the virus stays with you for your whole life. It grows, but not very much, because it's growing in cells that have the Fanconi pathway, so they can take out the trash and get rid of the virus, and doesn't build up and doesn't grow fast. And they've got good T cells that control the virus that's there. In somebody with FA, you've got good T cells, but the virus can grow so fast that you can get out of balance. You can get those white fluffy areas on the MRI that these people who came with the big lesions in the head never knew that they had. So the virus is growing too much. The T cells are not managing to control it. But what happens if the T cells get more powerful? The virus is growing fast. The T cells have gone crazy to try and control the virus, And then you get one of those big mass lesions. So all that white stuff around the big lesion is inflammation. Inflammation is caused by T cells that are going nuts. They've seen that the virus is growing too much and they're trying to fight it down. And these bright white lesions are what tend to give us the symptoms with the weakness in the side of the leg or the trouble with the eyes. So the steroids that both patient 1 and patient 2 got reduce the activity of the T cells, it reduces the inflammation, the edema, the fluid around it, and gets the system a little back closer to balance by pressing down on these T cells. You notice what it doesn't do is it doesn't make the virus go away. Because once polyoma viruses are in our bodies, it does tend to stay forever. But it can get, the steroids can get us back closer to balance and prevent these large white lesions, which are kind of dangerous and do look like a cancer. So it's important that people are aware to bring this up. So what did we see? Just to summarize this is a chronic syndrome. So as we followed people, we see some coming and going, a waxing and waning of the inflammation. And that's that teeter-totter changing its balance so that people will have new white fluffy lesions or big fierce lesions that can be controlled over time but not eradicated. And we can do this control, we can try and put things back in balance with steroids to restore it. I told you we've not yet seen this disorder in Fanconi individuals. This is very interesting, but it remains possible that this is just a statistical chance and we're watching it carefully. Being aware of this disorder is important because this looks like an aggressive cancer and a perfectly reasonable person could think that's what it is, and we absolutely don't want anybody being treated with radiation therapy if they chose not to do a biopsy or anything like that. So the main message I want to leave you with is that you have anything funny going on with your brain, let me know. You can let John Wagner know. We'd be happy to talk to your doctors and share what we know with them. This is my phone number, this is my cell, so call me anytime. And also ask your doctor if they would call me if they want to, because this is a very new thing, and we're learning more and it's changing over time. So Suzanne, I'm going to stop talking there and see if people have any questions.
Hey, Stella, thanks so much for that.
Sorry, Jordan, I called you Suzanne.
That's okay. We've been swapping on and off, so totally okay. Let's see, we have one question. Says, I've been diagnosed with lesions in the hippocampi bilaterally in 2016. I was followed by a neurologist for about 2 years and had many MRI. They discouraged me since there was no changes in the MRI. Should I still have follow-up with a neurologist and have annual MRIs?
If this person is interested, I would love to see your MRIs and look at them with our radiologist. This may be something different. This isn't the only funny thing that happens in the brain with FA, but it would be good to know. And I'm presuming this person doesn't have any symptoms. The whole thing is if they have symptoms, they would need to have an MRI right away. But if they want to contact me either through FARF or directly, we can have a look with our team at the images and have a chat about whether it's similar or different to what I'm talking about.
Okay, she said she'll send them along, and then that she did have memory issues since the beginning.
Okay, no, we would love to see them if she'd be so kind.
Okay, great. While we wait for a couple other questions to roll in, I have a couple, I have a couple questions for you. So is there a concern that a prolonged inflammatory response would lead to any cancer?
I think that's a great question, but not something that we have seen. Cancer can always be chronic inflammation always increases the risk of cancer, but we have not yet seen that with this. So I'm hoping the answer is no, but I don't think I know that yet.
Okay, thank you. It looks like Beth Evans has a question. Does this relate to higher liver enzymes?
That's an interesting question. I do not think so. JC virus and polyoma viruses generally don't hang out in your liver so much. They hang out in your kidneys and they hang out in your brain. So Beth, I think no, but you are quite right. It's really not clear a lot of the time why there is the elevated liver enzymes are quite so frequent in FA.
And Beth, talking is permitted. We've allowed that for you. So if you have a follow-up question to that, you can go ahead and say something. If not, we'll go ahead and move on to the next question. All right, moving on. Amitai has a question. You mentioned brain biopsy as being risky in cases like you presented with clinical manifestation and similar MRI. Would you recommend beginning steroid treatment as a first diagnostical measure?
How risky a brain biopsy is depends on where the lesion is. So some parts of your brain have got a bit of spare. You know, you can afford to have a bit missing. There are other places where you can't and where a neurosurgeon would never go. So the areas that, you remember we saw this in our MRI and it's at about 7 o'clock. In that area, you can reasonably safely do a biopsy. There are other areas where there's a high likelihood of damage to your ability to walk or talk and things like that, where a neurosurgeon would just say, I can't do that. In which case, yes, I think an early use of steroids would be the way to go. But it does just depend on where the lesion is. It's always better to have a biopsy to make sure that it's not something like a cancer. But you know, this is an important point Amitai is making. And what I'm worried about is that somebody might come with one of these lesions that is typical to us because we've seen them. And a reasonable doctor would say, it's an area we can't biopsy. It looks like a cancer. We're going to do radiation. And that would be a disaster. Mm-hmm. So that's why I'm excited for people. If they're having any trouble, just call so we can at least share this information with their doctors.
Thank you. We have a question from Michelle. She said, I was curious, did these patients that you presented have a lumbar puncture prior to having the brain biopsy?
So patient 2 would not be safe to have a lumbar puncture because the brain was so swollen. It's dangerous to do an LP in that setting. Patient 1 did, and we cannot see the virus in the spinal fluid. We were hoping we might, you know, we could do it that way and that would be easy because a lumbar puncture is much easier than a brain biopsy. But the lumbar puncture was actually not helpful. So great question, Michelle.
We have a question from Lauren who says, sorry if I missed this, but were the patients diagnosed with FA early or as adults? Did you see a difference between those who presented as FA early or as adults?
All these patients had been diagnosed in childhood. So not able to answer that question, but as a sort of matching part to it, in the patients in whom looking back at imaging and looking back at the history they told us, who'd probably had this thing going on at a low level for a while, we did see more stuff, more of that white stuff. So I think it is likely that you get more white fluffy stuff over time. But again, we're still learning.
Okay, we have a question from Sean, and it says, what would it look like in the kidneys then? So I guess, does this affect the kidneys at all? What are issues that impact the kidneys?
So JC virus just lives there. It generally doesn't hurt the kidneys. Another polyoma virus, which is very, very similar to JC, is BK virus. And BK virus reactivates very frequently in FA patients who are getting a transplant. And some people on the call may have had experience with this. Because it lives in the kidneys, it causes cystitis, and it's very annoying. It can cause bleeding in the bladder, and it can make you want to pee all the time, which is really irritating. And I think this is probably another reflection that FA cells can't clear polyoma virus. They can't do virophagy, this taking out the trash and getting rid of the virus. And we've known about this for a little bit longer than we've known about JC, that BK reactivation is very frequent in people with Fanconi anemia getting transplanted.
Beth has another question that says, what about high blood ammonia levels?
That's usually related to dysfunction in the liver. So I think that goes back to the question that, you know, there is something tricky about an FA liver, but I think it's probably not this.
Okay. Don't see any other questions at the moment. Let's see. I have another question for you. Are there any issues in the peripheral nervous system, or is it predominantly in the CNS?
Another good question. This far, entirely in the central nervous system.
Well, I don't see any other questions at this time, so we could potentially break early, unless I see any. Oh, we have one more. All right, one more. We'll let it go. All right, Sean has a question in, is the virophagy true for FA people for all viruses?
Probably not. So there's a lot of different kinds of viruses. Some are made of DNA, some are made of RNA, some are enveloped, they're wrapped in protein, some are naked. So we're talking about naked DNA viruses here. So probably not, but again, this is a new thing. This whole virophagy idea was only published in 2016, and seeing this clinically has been we've only been aware of this for the last 2 years. So we may learn more. And, you know, we've been listening to Susan Wells talking about HPV and other investigators talking about HPV, human papillomavirus, for years, where there is clearly a difference. So I think, Sean, it's only some. And we're talking here about naked DNA, which is strongly controlled by virophagy.
Great, thank you so much. We really appreciate you being here with us. I know you were here with us for a long time today, back to back, so we appreciate that so much.
Oh, you're so welcome.